All right. Hi, everyone. Thank you for joining us today. Today's webinar will be hosted by Dr. Alex Vaccaro, one of our spine surgeons and the president at Rothman Orthopadiecs. If you have any questions during the presentation, please feel free to enter them in the Q&A box at the bottom of your screen. We'll have time for about maybe 10, 15 minutes of questions, and I know Dr. Vaccaro will do his best to answer as many as possible. So you could take it away from here, Dr. Vaccaro.
Thanks, Natalie. Thanks for organizing this. So one of the most exciting things I do in my career, besides take care of patients with spine problems, is sort of diving deep into spinal disorders that plague us all. And I don't know if you've ever heard of spondylolisthesis. Spondylo means vertebral body. Listhesis means translation. So sometimes you develop instability, like the vertebral body moves on another vertebral body more than it should, and the body does not like that. So what does the body do? The body says, I've got to make that stable. So the joints in the back, and you have two joints at every level in the back, get larger and larger to stop the instability. And that crowds the nerves. And then people get back pain, leg pain, and they sort of get stooped over. And it's something that I see. I see it like at the age of like 35 to 50. You see it. Now, there's five different reasons why a spine may slip. The type I'm going to talk about today is the degenerative. This is just getting older. You could have a fracture, you could have a tumor, you could have a congenital abnormality called dysplastic, you could have a fatigue fracture, a stress fracture called an isthmic spondylolisthesis. But degenerative spondylolisthesis is when we get older and we develop instability. It's more common in women than in men. So it was first described, believe it or not, that not that long ago in 1950, forward displacement of one vertebral body and the other. And you could see how the nerves go through the canal and they get scissored, so it can cause significant leg pain. Now, the reason why the L4-5 level, remember, you have five lumbar vertebrae, is most affected is because the fifth lumbar vertebrae is below the pelvic rim, and you have all these stout ligaments that attach. So 5 is stable. So 4-5 has more stress, and it tends to be the one that slips. And then you may have, I talked about the joints in the back. Sometimes the joints are positioned in such a way that they allow forward movement. So just it could happen. So we see it more common in diabetic patients, more common if a woman has an oophorectomy, removing the ovaries, because the ovaries, estrogen is so good for bone health. And once you remove the ovaries, all of a sudden you start developing degenerative pathologies and things like this can happen. Now, the funny thing is, when a woman is producing a lot of estrogen, that can also cause laxity of ligaments. So you can see it with a younger woman, you have instability, and then you see it in an older woman who has no estrogen being produced. So it's interesting. So if there's a lot of stress on a motion segment, and if you have joints that may not be in the right position, they allow more forward and backwards flexion. That could be a problem. And the interesting thing is people always ask me, is it genetics or is it environment? And it's both. So in identical twins, we see that they both have it. So there's a genetic predisposition, and we know that degenerative disc disease is also genetic. So we have to keep that in mind. And if you look at natural history studies, does it slip a lot? Does it get worse? Well, it doesn't slip as much as other instabilities, but you can see it slip like 30% more than when it's first identified. And it's usually those involved in a lot of strenuous bending and twisting at the waist. So that can cause a problem over time. So this is a CAT scan, and you can see the joints in the back. And I don't know if you can see my cursor, but these are sort of vertical joints. So you could see how that would allow it to go front and back, front and back. So the first symptoms that patients have, they come to see us is, everyone has back pain. So they usually come because they start getting leg pain, leg heaviness, like the symptoms of spinal stenosis. So it's usually both legs are involved. Sometimes it could be one, but it's usually both legs. And it's usually in the sciatic nerve root distribution because L4-5 and L5S1 is a sciatic nerve. So that can be a problem. And when you walk, it just bangs the nerves, and it sort of cuts the blood supply off. So if you flex your back, believe it or not, you open up the capacity of the spine. So you see people as they get older, I say life is a kyphosing process because older people sort of bend forward because that opens up the canal more. So the nerves aren't as pinched as much and they have better blood supply. So that's interesting. And I always say, well, how can you tell the difference between leg pain and weakness due to a neurologic reason or leg pain and weakness due to a vascular problem? Because people can have vascular disease if you smoke, genetics. Well, the little trick is if you're walking and you start getting leg pain, And if you flex forward and you start feeling better, and the pain goes from your butt down to your feet, that's due to your spine. If you're walking and you stop and the pain goes away, it's probably vascular, and that pain goes from the ankles up to the butt. So that's how you tell the difference between a vascular problem and a neurologic problem. And sometimes you get it both. So you have to keep that in mind. So usually when I examine patients with a spondylolisthesis and they're not exerting themselves, the exam is completely normal neurologically. I see that they're sort of flexed forward. They may have a flexion contraction because they're always flexed forward, but you really don't see weakness. And I'd say in some of the cases up to 15%, but the vast majority has no weakness. And it's usually one of the sciatic nerve roots, L4 and L5. And if you get a plain X-ray, and that's the first thing we do is get a plain X-ray, you look at the spine and everything on this lateral view is in alignment. And all of a sudden, boom, one vertebral body is offset on the other, and you say, that's it. It's a spondylolisthesis at the L4-5 level. So take a look at these pictures. I gave you four different types of slippage. The first one, bone on bone slippage. The second one, a little bit of a slippage, but the disc space is preserved. The next one is you still have the disc space preserved, but a little bit of slippage. And this one, it's actually kyphosing. So it could come in any different form. And the number one study that we love to get, not a CAT scan. A lot of people get a CAT scan. I think a CAT scan exposes someone to radiation, and even one CAT scan increases slightly the risk of cancer. Get an MRI scan. No radiation, non-invasive, and boom, you could see exactly what's going on. Take a look at this picture. You have a slippage here, and you look at the top right picture, the canal is wide open, but if you come down to 4-5, see how crushed the nerves are? And it's because the body doesn't like instability. So the joints get bigger and bigger and bigger and they crowd the nerves. And then sometimes the joints fall apart and you get this little round thing called a synovial cyst. So you can see on the left on the side view and on the right in the transaxial view. And let me tell you something. When you have a synovial cyst that big, it is crushing the nerve root. And that's a problem. Now, we have spent a lot of time studying this, and the Rothman group has come up with a classification. And we like to classify so we can record, keep a registry, so we know what types of morphologies do well with non-operative treatment, what requires surgery, what requires fusion, what requires motion sparing. So the classification is really simple. Type A means you have instability, but you don't have kyphosis where you sort of bent forward. So that's not a problem. And if you go type B, you have the disc space is preserved, but it doesn't slip more than 5 millimeters. If a type C, it translates more than 5 millimeters and the disc space is preserved. And type D, you have kyphosis. So each one, and we're studying it, has a different prognosis. I can tell which one it is. I can tell which one is going to be very difficult to do a decompression only, which one needs an interbody spacer, which one needs instrumentation, just by looking at the morphology. And then the treatment options can go from doing nothing, which is what we do most of the time. Remember, most people get better doing nothing, or core strengthening, or intermittent anti-inflammatories. Very rarely do you need to see me as a spine surgeon. But if you have to see us, the treatment options go from minimally invasive endoscopic removal of pain to like complex reconstructive procedures. And I'll show you a few pictures of that. Now, I always like to go to the literature because the literature sort of directs us on what we believe the truth is. The greatest study ever done was Harry Herkowitz, where he didn't use any metal. He did a decompression and he showed that if you just put bone graft down, bone graft from you take the pressure off, you just recycle the bone graft. Those patients did better than those that just had the pressure removed on laminectomy. So it doesn't even have to heal. The fusion doesn't even have to heal. It just has to cause stickiness to decrease the motion. And they tended not to have recurrence of the stenosis. And then if you looked at studies that said, okay, well, let me put pedicle screws in to make it stay more stable. Well, studies have shown, well, they heal better, but it didn't really affect the outcome. And if you look at the classic control prospective randomized studies that had an observational cohort, and that was called the SPORT study, they showed that surgery, when you're really symptomatic, did better than if you didn't do surgery. So this is one of they followed these patients out to 4 years, and they showed that if you're miserable, you will do better with surgery up to 4 years out than non-operative care. And then other people took the same population. They said, okay, well, let's look at the different types of surgeries. Can I just use bone graft? Do I have to use metal? Can I use an interbody spacer? And it really didn't matter. As long as you did something that stabilized the interspace, it really didn't matter. Now, we like to look at type 1 level evidence, level 1 evidence. So we go to New England Journal of Medicine or JAMA, and the greatest paper ever done was Zohar Gagulaha from the Lehigh Clinic, where he did a multi-center controlled prospective randomized study. And he showed that if you did a decompression and added a fusion, those patients did better than a decompression alone. And then the Scandinavians did a follow-up study. Now, they didn't randomize for spondylolisthesis, so it's not as pure. So it's like a level 2, level 3 study. And they couldn't find a difference between fusion and not fusion, but they didn't quantify the amount of slippage. So this study is not as strong. And that's the problem with the literature. You really have to look at the methodology, to look at the confounders, so you don't commit a type 2 error statistically in making a decision. Now, when we see patients in the office, these are the questions that we ask as surgeons. Which patients can I just do a minimally invasive endoscopic approach on? And the literature says that those patients exist. This is a systematic review that says, yes, a decompression alone can be effective, and many people looked at it. And what I look at is how much instability on flexion extension. Does it move a lot on flexion extension? If it moves a lot, I get nervous. So absolute indications for me, if it really moves a lot, I do a fusion. If the joints are positioned in such a way that they have it and they're oriented in the sagittal plane, which means there's no buttress, then I get nervous. If there's a tall disc space, which means there's a lot of flexibility, I get nervous. And if I see a lot of instability, I get nervous. Now, here's an example of what I talked about the joints in the back. See on the far left, those joints have sort of a buttress. It's not going to move very well. But if you look at the joint on the right, it's more in the sagittal plane, and you could see how that can easily go back and forth. So that one, I would probably fuse. The one on the left, I probably wouldn't. And you just do these angles. And if that angle is greater than 50 degrees, it's a little bit too sagittal and it may slip. So these are the things I look at. Now, if you see collapsed disc, these little bony osteophytes, that's not moving. So this patient can have an endoscopic minimally invasive decompression because that's not moving. Now, if you have to get aggressive and you have to really take a lot of the joint out to take pressure off the nerves, well, now you caused iatrogenic instability. That means instability caused by the surgeon, and I'm going to probably fuse that. Now, people have gotten a little bit creative and they say, well, maybe we don't have to fuse. Maybe we can put screws in with a cable. And a lot of the papers in the day came out and said that can work. And this is called the graft ligamentous system. There's no fusion, but like everything else in life, what looks good for the first few years, the body really doesn't like something that moves a lot without stability. So this has fallen out of favor. And another group of surgeons created a facet replacement that they've had good results. But the amount of anatomy you need to remove to put this device in is so significant. I stay away from it because that's a very big operation. So you have to put it together. Now, sometimes when we do these surgeries, we like to go between the disc space to lift it up, to change the alignment, to give it stability. And we really have not been able to prove that changes the outcome. We know it increases the chances of healing because you have more stability. It's like a circumferential front and back, but we really haven't been able to show that there's a clinical difference in outcome. Now, say you're totally against having a fusion procedure. Say, listen, I just want to have a decompression, and you don't have a collapsed disc, you don't have osteophytes, you don't have minimal motion. You're taking a chance. So studies have looked at that. They said, okay, what happens if I have a decompression, it fails, I get miserable, I come back? Well, studies have shown that you don't do as well. So you don't want to fail. So if you have all the indicators for instability and you don't have stability, then it may be in your best interest to have a fusion. And I want to end with this. I tend to talk quick because I was born in New York and I have to apologize. But I think I covered it. But this is an example of a person that came into my office that was bent over, that couldn't stand up straight. And this wasn't a minimally invasive endoscopic decompression. This was making an incision in the front, putting wedges in, lifting the body up, and then going in the back and putting screws and putting pelvic bolts in to give stability. And this patient did great. So we go from minimally invasive endoscopy to a laminophragmectomy, tubular decompression, laminectomy, laminectomy infusion, laminectomy infusion with instrumentation, laminectomy infusion with an interbody spacer, and then a big reconstructive procedure. So there's no one method fits all. You have to individually look at the patient. But I want you to feel comfortable that 99% of the time, you're not going to need me. You just have to keep your core strong, exercise, and you only come to see a doctor, a spine doctor, when your legs are killing you and you're not happy because you don't want to be that person that just says, okay, I'm just not going to do anything because you're going to get heart disease, you're going to get out of shape and stuff like that. So that is an overview of one of the more interesting spinal deformities, spondylolisthesis and slippage. And now I'm going to open it up to the audience. Natalie, hit me with the questions.
All right, sounds good. Can you hear me okay?
I could hear you.
Perfect. All right, there's a few questions that came in, so we'll go through most of them. First question is a fusion permanent or does it need to be modified at some time?
Well, the fusion, if it works well, is always permanent. So what is the downside of having a permanent fusion? Well, you're not moving there anymore. So the movement occurs above and below. And you have a chance, and it's 2.8% per year, maxing out at 30% over 10 years of developing arthritis above and below. So the downside of a fusion, and we do fusion for scoliosis, we do fusion for tumor, we do fusion if you break your neck. So we do it and it works great. But the downside is it makes that segment stiff. Now, if you have one level done, you're not going to perceive it. Studies have shown you don't perceive a one level fusion. But if you have two levels done, you may feel a little bit like I don't have full range of motion. So that is the downside of a fusion.
Thank you. Next question is, what is the difference between spondylolisthesis and spinal stenosis?
Well, they're totally different. Spinal stenosis is just narrowing of the canal. So when you have spondylolisthesis and you have that movement, it narrows the canal. So spondylolisthesis without narrowing the canal causes back discomfort. But when it narrows the canal, causing spinal stenosis, which is narrowing of the canal, that's when you become symptomatic.
All right, thank you. This person said they had an L4, L5 spondylolisthesis bone fusion at age 14 from a motor vehicle accident. Now they're 45, no real issues. That being said, they have degenerative changes in their neck. Was that most likely caused in the 30 years from that spinal fusion? They were,
Well, that's
remember,
interesting. Yeah, so at L4-5 trauma, that's called a traumatic spondylolisthesis, traumatic. And I said before there's five types: isthmic, dysplastic, tumor, trauma, and degenerative. But that 14-year-old had a traumatic spondylolisthesis, and the junctional breakdown is usually the level above or below. It's unusual. So the neck may be just separate genetic, so the neck may not. But if you have degenerative changes at L3-4 or L5S1 or L2-3, that could be the result of. But you're a perfect example of someone who doesn't really have any symptoms in your back. So people get nervous. I'm like, listen, you're only doing a fusion if you're going to be much better off. You don't do a fusion if you're not going to be better off. So you'll be better off doing the fusion than without the fusion if you check the boxes for instability.
thank you. Next one is, do these benchmarks also apply for congenital issues? Is a good benchmark when the pain is unbearable? And is there a drawback to getting a fusion before the pain is unbearable?
Yeah, I'd say in general, if your functionality is compromised, you're going to be a little bit nervous to have surgery, but you do everything you can non-operatively. But if your function continues to be compromised, most patients, when they finally do it, say, you know something, I wasted 4 or 5 years of my life. If you're miserable or if you have loss of function, that's when you should do it. If you're not miserable and you don't have loss of function, you don't do it. So, I'd say what percentage of people that come to me that have this end up having surgery? I'd say 5%, 5 to 6%. Now, if they get referred into me because they failed non-operative treatment, that number's higher. But most of the time, you don't need surgery with this. You can manage with non-operative care.
Right, thank you. Can you give your opinion on the Minuteman procedure?
Yeah, so the Minuteman is described as being a spinous process clamp. So it goes back to what I said before. You put a piece of metal in the spine, but you don't provide stability. So I've seen devices like that loosen over time. So I'm not supportive of it because I think it will eventually fail. and it may be a problem. Now, if you're the manufacturer of the Minuteman device and you ask this question, I apologize. But you asked my opinion. I'm not a big fan of any device that goes in that clamps two levels together that move. I think it's going to have to loosen over time.
All right, thank you. Someone said, what happens if you have osteoporosis and you're a woman?
That's okay. That's a good question because so if someone comes into me if they have osteoporosis. If they're absolutely miserable and they can't walk, I'm going to operate. But there's so many problems that can occur. If I put a screw in, the screw can loosen. If I put cement in to make the screw more stable, there's this chance the cement may extravasate and go into the canal or embolize to your lungs. So I still operate, but I want to try to push out if I can. But thanks, Anthony. A lot of people are miserable, so we operate. So you just want to try to minimize instrumentation, minimize the size of the surgery. So you can have surgery, but the complications are going to be great. If you put an interbody spacer in between the two vertebral bodies, it may subside because the bone's not that strong. So I mean, if you're not miserable, of course you won't have surgery, and then you want to, get a DEXA scan, find out what your house field units are. You want to get on the appropriate medicinal strategies to improve your bone health, and then you have surgery. But if you can't, if you develop a neurologic deficit or excruciating pain, then the surgeon has to use different tactics to minimize a complication.
Right, thank you. Someone asked, what do you use when you do a fusion?
I'm an old-fashioned guy. I don't like to use anything else besides the patient's own bone. I sort of laugh when they use this biologic, that stem cell. I think it's a waste of time and a waste of money. I take the pressure off the nerves and the bone that I remove, I recycle so it doesn't get rejected. So I use the patient's own bone. Now, it can be a difficult time if it's a revision procedure. Say the patient had multiple procedures, then I may have to use an additive. But 99% of the time, I don't have to use anything, but I have ways of shaving the bone to take the pressure off the nerve to recycle that bone. So the patient only gets their own biologics in their body.
Great, thank you. Does spondylolisthesis cause radiculopathy or myelopathy?
Yeah, well, it causes radiculopathy, which is leg pain. Now, the term myelopathy means spinal cord dysfunction. If you have a slippage at the level of the spinal cord, it can cause myelopathy. But this is usually at L4-5, L5-S1. But I've seen slippages in the thoracic spine, and I've seen slippages in the cervical spine that have caused cord compression, and that causes myelopathy. So radiculopathy is an unilateral extremity. It could be the arm or the leg. Myelopathy is the spinal cord itself.
Right, thank you. Someone asked, I guess when you're mentioning non-operative care, what does that entail?
So it could be as simple as just going for a walk every day with your partner. That's the best non-operative care. Nothing crazy. And then you can take it from there. You can go to a therapist. You can do the treadmill. You could do the cycle. You could do the elliptical. I'm not a big fan of running if you have a bad spine problem. I don't like the pounding. I like to baby the spine if you have a bad spine problem. So that's not operative care. You can take intermittent anti-inflammatories. You never want to take a narcotic for spine problems. Unless you're post-surgical, stay away from narcotics. It doesn't take you anyplace good. I don't even like to give gabapentin. The gabapentin for me is something that you give to someone who develops, a neurologic pain syndrome after they've had surgery, when they have dysesthesias and stuff like that. People go to gabapentin way too early because it makes you a little foggy and stuff like that. I like intermittent anti-inflammatories, stretching, and patient-directed physical therapy. Maybe go once to a therapist, figure out what to do, and do it on your own.
Right, great, thank you. Is there an age limit on when you can get a fusion?
No, I have done I have done fusions. I don't like to. Patients in their 90s, believe it or not, they come to me and I'm like, oh, I don't want to do this. I mean, anything can happen to a 90-year-old in an operating room, but they're like so spry and so functional, and that they're miserable, and I'm like, this is not good for me or good for you, and I've done it before 90-year-olds.
Wow, okay, great. Let's see, some great questions here. Someone said, will removing screws after 5 or so years give more range?
No, because if you had a fusion, the screws are it's like putting a plate on a broken arm. The screws are there for the bone to heal. Once they heal, there's no motion. So taking the screws out. Now, if you didn't heal, then you may have more motion. You take the screws out, but usually you've healed, so that doesn't change mobility.
Okay. This person said they have major scoliosis and have been told if they pursued surgery, it would be major. Is that someone that you would see, Dr. Vaccaro?
I see that. It all depends what you need. If you have a flat, what happens with scoliosis is patients develop a flat back posture. It doesn't have to be that major, but you have to get an assessment. You'd have to get scoliosis x-rays, bending views. You'd have to find out the level of the pain generator. It could be small. Sometimes it could be large, but it doesn't have to be large. So I would get assessed first to find out what's going on.
Okay, thank you. This person said they have spinal stenosis and where it's not really a question, but they just said they have spinal stenosis and worry that their spinal canal may eventually narrow so much that it will cause paralysis. Can that happen?
Well, it can happen in the neck and thoracic spine paralysis. Usually in the lumbar spine, it can cause something called cauda syndrome if it gets really, really narrow. And that means you have urinary hesitancy, urinary incontinence, perineal numbness. So I would definitely get checked out if you're starting to get miserable to make sure that doesn't happen. But the vast majority of the time, you don't get paralyzed from spinal stenosis. You're just miserable. So the good thing is you don't get paralyzed, but you're not happy.
What is your opinion on spinal cord stimulators?
Well, I love it for someone who has had the appropriate surgery and they have neuropathic pain. It is the greatest thing in the world for neuropathic pain. It makes people really functional. I'm not an advocate of it as a primary treatment because there's something mechanical going on. I would deal with the mechanical problem first. And if that mechanical problem is remedied and the patient's still symptomatic with extremity discomfort, I'm a big fan.
Okay, great. Another question is there a relationship between lumbar lordosis and spondylolisthesis?
Well, yes, if you lose lumbar lordosis, lose it, you tend to see that with spondylolisthesis. They tend to slip forward. So lumbar lordosis is just describes the sway back in your back, and there's measurements you use. So alignment is associated with spondylolisthesis, and it's really complicated, but there's different classification systems called the Russell classification system, the Schwab classification system. We look at something called pelvic incidence, and we look at lumbar lordosis, and pelvic incidence minus lumbar lordosis should be 9 to 10 degrees. So very complex. These are things we do as surgeons when we look at your X-rays.
Thank you. What are your thoughts on epidurals to manage pain, and how often do you recommend them?
So if you look closely at the literature, epidurals work 60 to 70% of the time. So I'm a fan. If it if you think they're going to help you out, go for it. You know what I mean? If you have severe stenosis, I'm not a fan because I'm afraid the extra volume is going to cause a neurologic deficit. I'm not a fan. But if you want to avoid surgery, go for it. I'm a big fan.
Okay, great. Is aquatic therapy recommended for lumbar pain?
Love it, love it, love it. I just can't get enough people to do it. I I'm in the pool like 3 days a week. I think it's the greatest thing as you get older. Make sure it's warm. Make sure you stretch. Get those underwater headphones and have fun.
Great, thank you. Could numbness in the leg caused by L4, L5, L5S1 be reversed?
Yeah, I tell people when I operate and they have really bad numbness, 50% of the time it gets better. 50% of the time it sort of lingers. So yeah, so 50% of the time it gets better.
Okay, great. Couple of questions about stenosis. If surgery can get rid of stenosis, if you'll operate on someone with stenosis.
Yeah, and the surgery is great. So stenosis, as I said before, is narrowing. So that's what a surgeon does. A surgeon has so many techniques to make the narrowing larger. So we trim things, we open things up. We can do a laminoplasty, which means we open up the hood. We can do a decompression. So yes, spinal stenosis is something surgeons do well. They can get rid of it by opening up the canal.
All right, great, thank you. Right, lots of good questions coming in. Someone asked, what does an allograft do?
An allograft is just a piece of bone from someone who's deceased. So you could use your bone, or you could use a bone from someone who's deceased, and you just want to make sure that you understand their sterilization process. So it can't be irradiated to the point that it doesn't have potential to heal, but it can't be like I'm not a big fan of allograft stem cells because if it's not if it's not sterilized, there's chance for disease transmission, and occasionally you'll see that with allograft stem cell products. So, but allograft is great for structural support. If you look at the picture that's on the screen right now, that's allograft, and that's bone from the femur of someone who's deceased, because that avoids you taking from a patient's body.
Okay, thank you. Another question. Does spondylolisthesis cause neuropathy?
Yeah, so neuropathy is just, if you look at the definition of the word, it's pain in the leg. I like to use the term radiculopathy, but neuropathy infers something different, infers that there's something wrong with the autonomic system. So it's not just the peripheral nervous system. So if your definition of neuropathy is leg pain, yes, spinal stenosis causes that. If your definition of neuropathy is a neuropathic pain that's due to some sort of problem with the autonomic nervous system, spinal stenosis would not cause that. So it's a little confusing. But radiculopathy, yes. Neuropathy, well, if your definition is leg pain, yes. But usually we use it for something totally different, that descriptor.
Okay, thank you. Someone asked for your opinion on nerve blocker and radiofrequency ablation injections for lower back pain.
I'm a big fan. If you have back pain that's not due to anything bad, give radiofrequency ablation a shot. It sort of denervates the pain sinovertebral nerves to the facet joints. Nerve blocks are just used for diagnostic reasons. Say, is it the L45 nerve? Is it the L5S1 nerve? What is it? So you do a nerve block, and every time you inject, and if it's reproducible, that your pain gets better, you could say, well, that's the level where the pain is coming from. So I support that totally.
All right, thank you. Opinions on if a cortisone steroid injection helps for sciatica.
Yes, it can. So as I said before, 60 to 70% of the time it's effective. 30, 40% of the time it's not effective.
Okay, thank you. Is a wait and see recommendation appropriate for a disc bulge into the cervical spine with no symptoms?
Definitely don't touch it. Stay away from me. Don't come near me. You'll do fine. Disc bulge, yeah, treat it non-operatively.
Perfect. Okay, thank you. All right, there's a couple more questions. Well, there's several more questions. I think we have a little bit more time. Let's answer a few more. Great questions. All right, someone asked, how do you slow down lumbar lordosis? Or can you slow it down?
Well, lumbar lordosis, you want to have you want. I always look at it this way: thoracic kyphosis, you want to have 36 degrees on average in an adult. Lumbar lordosis, you want to have 45 degrees. You really can't change it because everyone has a different body habitus. So you just want to stand straight. So that's all you can do, and you're just hoping that your spine isn't bent over, isn't twisted and wrong. I mean, if you have poor posture, that can cause more advanced disc degeneration. You could lose your lumbar lordosis. The fear is you lose it and you develop a kyphosis, which is bending the opposite way. So just try to, stay in shape. Try to stand tall and work on your posture.
Okay, thank you. Does PRP, I guess they're referring to PRP injections in facet joints help spondylolisthesis?
No, it's just that's a treatment for pain. It's not going to help. It's not going to help spondylolisthesis.
Gotcha. Okay. This person said they recently found out that their L5 dropped in height, perhaps causing a decompression fracture. How serious is it? How serious is it? Because they're not experiencing any problems yet. No symptoms.
Yeah. So it is serious because you have to find out why you develop a compression fracture. You have to find out what is the underlying cause of the osteopenia or osteoporosis. So it is serious, and you're fortunate that you don't have any symptoms, but find out why it happened. Go to your medical doctor, get a DEXA scan, figure out what's going on.
Right. Thank you. This question says, I don't know if I'm going to pronounce it correctly. Can anything non-invasive be done for a 90-year-old with cauda equina?
Okay, if you have Cauda equina syndrome,
Coda equina.
you need to have surgery. I don't care what age you are, unless you can't tolerate surgery. But Cauda equina syndrome is impending paralysis, loss of bowel and bladder function. You don't fool around with Cauda equina syndrome. Don't fool around.
Okay, thank you. Right. Someone asked, what do you think of the TOPS system?
Well, that's why I showed you that. I think it's very aggressive. The top is just a facet replacement. And I showed you a picture of how much of your anatomy you need to remove to put that in. And then God forbid it fails. So I'm not a fan.
Okay, thank you. All right, someone said thank you for taking time from your busy schedule to provide this interesting webinar and answering questions.
Well, thank you, Natalie. You've done a great job. Natalie's really the one that puts it together. She's a superstar. So I want to thank everyone for attending. I really enjoy, I love talking about things. Every quarter, I'll talk about a common spinal pathology. So I'll see you in 2.5 months.
Thanks, Dr. Vaccaro. And we did record this. We will be sending it out. If you have any interest in making an appointment, feel free to reach out to me directly. You all have my email. Thanks, Dr. Vaccaro. Thank you, everyone, for joining. Have a great night.
Take care, bye. Bye-bye.